Good afternoon, everybody. Today we have a very special interview coming to us. It's in connection with the Ernest Beutel Prize, which is a prize which I didn't know before, but I found out, and it's a very important distinction for hematologist doctors. And I will read it to you, what is for public information, because I cannot remember all the things, so I don't want to make any mistake. So it says the Ernest Beutel Lecture and Prize. Professor Skoda, the recipient of the Ernest Beutel Lecture and Prize in Basic Science, is being honored for his role in discovering a frequently occurring mutation in the JAK2 gene and providing mechanistic insights into the development of myeloproliferative neoplasm, MPNs. Dr. Skoda's research team at the University Hospital in Basel, in Switzerland, determined that the mutation leads to overactivity of a JAK2 protein in a single blood stem cell, allowing it to divide rapidly and displace normal blood cells. His work provided the foundation for developing JAK2 inhibitors to manage symptoms in individuals with MPNs. Dr. Mesa, the recipient of the Ernest Beutel Lecture Prize in Clinical Science, is being recognized for his essential work in clinical trials with JAK2 inhibitors, including those for ruxolitinib, the first JAK2 inhibitor approved by the US FDA for myelofibrosis. He led the development of two standardized tools for assessing symptoms in patients with MPNs, the myeloproliferative neoplasm symptom assessment form, the MPN SAF, and the myelofibrosis symptom assessment form, which is MSAF. These patients' reported outcomes measures were critical in supporting the approval of multiple JAK2 inhibitor therapies and have become the gold standard for patient-reported outcome assessment in drug development across medical disciplines. Together, the work of Dr. Skoda and Dr. Mesa has paved the way for the development for FDA approval of JAK2 inhibitor therapies for MPNs, providing patients with reduced symptoms and a better quality of life. I think it is very important that especially young patients, they know, what has been doing many years ago. But I'm diagnosed since 30 years on my PV, and I remember these days, MPN was a big black hole, really. We had very little instruments to battle against it. And it's thanks, once at the work of Dr. Silver and Dr. Heinz Gislinger, who started with the old interferons. But this prize shows how important it is that two persons like Rodek and Ruben, the work which you have been doing, which is absolutely amazing. And thanks to you, we do have a much better quality of life than we had before. So this is why it's a great honor for me to present you here Dr. Ruben Mesa and Dr. Radek Skoda, which I know both of you for many years. And you always have been cooperating when I was asking for it. Thank you for this. So we would like to talk to you, with both of you, a little bit about how was the beginning when you started your work, which was just I explained just now. Where are we today, and what do you see it from a future of your point of view, which each of you has a complete different work to be done, but they are combined one to the other, which is giving us the final result. So welcome, both of you. Thank you much for coming. And as I say, the floor is yours.
Well, thank you very much, Peter. It's a great pleasure to be with you, at least online. And as you said, we know each other for a while. And, patients like you are, for me, and I'm sure also for Ruben, the great motivation to do our research. Because, yes, we are very interested in improving the details, but to see patients like you living with the disease for 30 years, that's a great payback for us.
Ruben?
Let me just echo both the thanks and the welcome for being able to kind of visit with you both today. For those kind of tuning in, this award was started many years ago at the American Society of Hematology, obviously in honor of Dr. Beutler, and tries to tie together a key scientific discovery and then the subsequent impact that occurred clinically. And there are many well-known examples, but I'll raise just one. So the discovery of the Philadelphia chromosome and BCR-ABL, and then the subsequent development of imatinib and the tyrosine kinase inhibitors, or CML. And there's numerous kind of other examples. Now, I think as both Roddick and I received notification of this award, I think we were both duly honored, but also very much recognized that we were each just part of each community, the discovery science community that discovered the V617F and helped to unravel the broader pieces. And clearly, myself as a clinical trialist, I'm but one of a dedicated core team of individuals across countries and institutions that really had this as an area of passion, trying to make a difference so that MPN patients would have more options and we would hopefully be more effective against the disease. But the first step in this is clearly the discovery science. So Radha, maybe walk through for patients a little bit, what did we know before the JAK2, a bit how this was found, and there were several labs that were kind of there at the beginning. William Benchiker probably first, but many others that were including your lab most crucially, that were both involved with the initial discovery of this, but also really the subsequent characterizations that really have led to a lot of important pieces.
Yes, so you summarized it very well. In my case, obviously, this discovery of the JAK2 mutation was done by several labs. So the fact that ASH has selected me, I feel that this prize would have been just as well given to one of the other three, which is William Weinschenker in INSERM Paris, Villejuif. There was Gary Gilliland at Harvard, and Tony Green in Cambridge University. So I feel very honored, but also I would like to make clear that I feel that this prize is giving to us, to the four of us, and to the team and to the field of MPN, which, as Ruben said, made a huge progress since the discovery of this mutation. So yes, I started working on MPN because during my postdoctoral fellowship, I was studying the mechanism of, at that time, orphan cytokine receptor, which then turned out to be the receptor for thrombopoietin, the growth factor that promotes platelet production. And first I studied inherited forms of thrombocytosis, and we discovered mutations in the thrombopoietin gene, and that was sort of the start of my career. But then being an MD and doing some part of my time in clinical service, I became obviously then interested in related diseases that are characterized not just by thrombocytosis, but also high red cell mass. And so that was my entry into the MPN field. I saw patients in the outpatient clinic in Basel and started the observational cohort, collected samples, and so that was really the starting point. And at that time, it was essentially nothing known about what causes the disease, and there were only 3 or 4 therapeutic options: phlebotomy, hydroxyurea, aspirin, etc. So I felt that this is a great niche project for a starting junior faculty researcher, because nothing was known at the time, and also it's a disease that obviously causes overproduction of blood cells, and so it's easy, and patients are motivated to give blood. Many of the patients also at that time were treated with phlebotomy. So it was an ideal starting point, and the community was very small. So we had the initial meetings. There were maybe 20, 30 researchers, clinical, and people that already Ruben mentioned. Richard Silver was there, Tiziana Barbui. Some of the figures that made huge impact in the clinical development of diagnostics and therapies. So that was my starting point. And then I was, in respect to the JAK2 mutation, I was lucky because the groundwork to our approach was laid by Robert Kralovic, who was postdoc at that time in Joe Prakal's lab. And he discovered a important phenomenon that to this day is part of what we're trying to understand in MPN. That is that part of the chromosome 9, where it turns out JAK2 is located, becomes sort of homozygous. We call it uniparental disomy. So he described the loss of heterozygosity on chromosome 9. And at the time when he was still in Joe Prakal's lab, he started mapping that region. He then joined my lab. At the time, I was in Heidelberg at the German Cancer Center, and we decided to fine map that region. And this was the approach that my lab has taken, and in the end led to the discovery of the JAK2 mutation. So yes, I came into the field for two reasons. One is that I was an MD and I was looking for a disease that I could understand and contribute. The disease was essentially unknown in pathogenesis, and it was also in retrospect probably the best decision I've made scientifically. And I'm very happy that things have evolved as they have.
Thank you very much, Radek. How was it? How was your beginning, Ruben?
So I saw my first patient with myelofibrosis when I was a medical student, along with Aylu Teferi, who was at that point still a fellow at the Mayo Clinic before he went out of the faculty. And that individual, this is the early 1990s, she was a young lady from Venezuela called Veronica. And she had massive splenomegaly, one of these huge spleens that we see where she could hardly stand upright. And she came with her husband as well as her small child from Venezuela to Mayo. Mayo had deep expertise at that time, although we had limited options. And one of the options we used to do was splenectomy. So she had a splenectomy. And then sadly, 3 days post splenectomy, she had a delayed hemorrhage and passed away from the disease. And I took this very hard. It was very traumatic. Certainly did not anticipate that was going to be the case. And so I started working with Aylu because I was both fascinated by these diseases as well as there clearly needed to be more things developed. So under his mentorship in training, was involved with many clinical trials with MPNs before eventually joining the staff of Mayo Clinic. And in that era, we were trying anything we could get our hands on. There were a lot of physical things that were being done, meaning physical type therapies, radiation therapy to the spleen, radiation therapy to the lungs for pulmonary hypertension, splenectomy. People were trying splenic embolization. Medical therapy, we didn't really understand the biology very well. I mean, that was a fundamental barrier. So we were trying to beg, borrow, and steal drugs from other areas. TGF beta had been found to be elevated by histology. So we tried a anti-helminth agent, Suramin, that was an anti-TGF beta drug. Well, it was both toxic, but it didn't work. We tried one of the first trials I wrote as a trainee was a trial of pirfenidone, which was an anti-fibrosing agent being looked at for pulmonary hypertension. And, it had a reasonable rationale, but we didn't know the biologies to know well enough whether it would work. And it didn't work at all. So trials were really just pure trial and error to see whether they'd have any activity at all. There was really no good animal models to really be even able to test drugs. And then we had observed, activity of the immunomodulatory drugs such as thalidomide to improve anemia. And part of the rationale for that had been that we had seen an increase in neovascularization, and there were thought to be anti-angiogenic properties of the IMiDs, which is why they were tested in myeloma first with activity. And we had gone down a whole rabbit hole of trials for thalidomide, lenalidomide, pomalidomide to have an activity. But prior to 2005, that was really our situation. We didn't have that biological underpinning to really guide a rational drug development program against MPNs. There was no company developing drugs specifically for MPNs, and had no real focused programs on this. So when the discovery of the JAK2 V617 came out, it really was incredibly exciting. I was just one of the contributors to the project led by Dr. Gary Gilliland, and his lab had come at it from an angle mapping the kinome, just the broader kinome of MPN patients, based on the relevance of BCR-ABL in CML, and had done that from blood samples from patients that had participated in one of our earlier MPN patient conferences that were being held every 2 years in Arizona. So that discovery, again, led to us to be really, really excited that could an agent be developed that could then really have an impact on MPNs.
Thank you very much, Ruben. So I assume, Radek, for you also, the discovery of, or you participated of a JAK2 was a milestone in your work, no?
Yeah, absolutely. Of course, it was a very exciting time, and I think the most important part of it is that it really opened up new perspectives and energized the field, and led to also to much more investment into research and then clinical development. So being at a relatively small unit in Switzerland, which was mostly dedicated to allogeneic transplantation, so I didn't have really the access to clinical trials, etc. And so I concentrated on the basic research surrounding the many questions that opened with the discovery of the mutation. One of them being that as a kinase, of course, it was obvious that drugs could be developed that could inhibit the enzymatic activity. And so my contribution then was that we early on developed mouse models. We introduced the same mutation that are found in patients into the mouse, and that mouse developed the same disease as patients. And that was an important part, and that was then asked by several companies that started developing inhibitors to use this mouse model as a preclinical test to select the best compounds that were then further tested in clinical trials. So that was one part. The other is that we started to be interested in the stem cell hierarchy and the stem cell organization of the disease, which I think is still key to understand and to develop curative therapies. We learned that the disease is maintained from a pool of stem cells, which are hard to reach by therapy. So we have effective means of eliminating the products, that is the excess of red blood cells and platelets, etc. But the disease keeps being regenerated from a pool of stem cells. And so I invested quite a bit in understanding how this stem cell pool is maintained, how it originates, and I think this is for the future the goal. We have now a growing number of therapies that can improve the course of disease, also quality of life. But the ultimate goal has to be that we should be able to eventually cure the disease or to push it back so that patients have a completely normal life. So this is what still is motivating me and driving me in my research.
Thank you, Radek. So basically, after the YAG2 discovery, we to nowadays, today we have many products, especially for myelofibrosis. Still, new are coming out, but I think myelofibrosis has made very big advances in treatment. I think we're a little bit behind on PV and ET. My opinion about if we could chronify PV and ET, we would have less MF patients. But I think also there, you're working very hard in order to try to get it. What can you explain us, Ruben, after, YAG2 was there and, the developments which we have had in the last, 10 years or something like that? And
So 20 years. So the JAK2 discovered in 2005. Well, let me walk through people what that process was like, because I think it's both helpful to understand, both why does this take so long, what has been the benefits we've seen, and where does the future go as well. So the discovery occurs in 2005. And at the time, there were some companies that had already had an interest in this broader pathway that we call the JAK-STAT pathway, because this pathway has a range of different things for which it is important. It includes things such as the creation of some of the blood cells. So the JAK-STAT pathway is important for the creation of red blood cells, white blood cells, and platelets, but also can be active in various autoimmune conditions or others with overactivation. So at that point in time, the first company, Insight, which remains a very active company for MPNs, was at that point a small offshoot within the broader chemical company of DuPont. That is both a chemical company as well as had a kind of a biopharmaceutical piece. And this was kind of a subset of activities with a range of different JAK inhibitors. And they were then able to test after the discovery that found one of their lead compounds, which ended up becoming ruxolitinib, or at that point had a name INCB 018424, that had activity against the JAK2, mutation. It was active against overly activated JAK2. The JAK inhibitors up to this point in time have not been specific just to the mutant form, but have been targeting the JAK-STAT pathway, and that's an important piece. And that feeling that the JAK2 mutated cells would be more sensitive to the inhibition of JAK2. So that was the first drug that went into clinical trials. Now, for a drug to go into clinical trials, it has to demonstrate in the lab in some way against mice, against cells, that it is active against the target for which you are aiming. And then second, that they have an idea of dose and safety. So animal studies are done to get a sense of what is a reasonable starting dose, as well as, is the compound safe in terms of any harm that it could do to the liver or kidneys or skin or other areas, to be tested in humans. And then they typically start, lower at a lower dose than what they expect might be the correct dose, to be sure that they start with the least amount of side effects, and try to discover the dose. So that's what we call kind of phase one. So it was around 2006 that the very first phase one, first in human, to receive a drug like this occurred both at Mayo Clinic and at MD Anderson, where we were working on this phase one trial together. So again, as I had mentioned, that the clinical trial piece has been the work of many. Just a partial list of key folks to include would be Serge Verstavchik, of course, which has been central to most of these studies. Hagar Kantarjian, who was his colleague and at that point his boss at MD Anderson. Other key figures across the trials, I'll just name them now because there are so many, but Claire Harrison, also really front and center, played an essential role really across all of these studies. Jean-Jacques Kilajan, Alessandro Vanucci, my former mentor, Ayulu Teferi, of course, involved with many of these agents, both in the beginning and later on. My former colleague at Mayo, Animesh Pardhanani, John Mascarenhas, kind of joined in about kind of midstream, but played a very important role, as has Ron Hoffman from the beginning, Francesco Passamonti, Jason Gottlieb, particularly with the whole momelotinib story, Vikas Gupta in many of these studies, Giovanni Barossi, particularly at the beginning of this arc, and then Francisco Cervantes from Barcelona, from where you are at today, Peter. So this is just even a partial list, just of the folks involved really specifically with the JAK2 inhibitor trials. Not to remotely leave out all of our really MPN leaders, Dr. Barbui, Richard Silver, and so many others that have been instrumental really in advancing kind of MPN therapies. So that's how we got to the first drug, ruxolitinib, into the phase one trials. Now, the first question that was asked really at the beginning is, if you inhibit JAK2, what is the benefit that you're going to see? Who should we treat? Again, no one had been treated. Who should we treat? What would success look like? So the discussion at the beginning actually was, should we treat patients with polycythemia vera? Polycythemia vera has by far the highest percentage of patients that have the JAK2 mutation. Myelofibrosis, it's about half of the patients. Should we start with PV? And in discussion with the regulatory bodies, the FDA in the US and the EMA for Europe, it was agreed that although PV might be a logical place to eventually test the JAK2 inhibitors, that until we knew whether the drugs were safe or effective, it was probably more prudent to start with the patients with myelofibrosis, because they needed a therapy sooner, because they were more ill, because drug development typically starts with the patients that have the greatest unmet need. So the phase one started in patients with myelofibrosis. And even the regulatory bodies said, well, why don't you start with those patients that are the most sick? Start with the intermediate to and high risk by the IPSS risk scores until we know whether the drug is effective. And that is where we began the trial. Now, when we started, we didn't know necessarily what would be the outcome. We developed response criteria through the International Working Group for Myelofibrosis. We wondered whether we would see the bone marrow go back completely to normal. Would the disease go into a remission? We didn't know. But what we did see was, one, the most dramatic improvement in how patients felt compared to any other therapy we had tried. So again, had been involved with about 30 different trials for myelofibrosis before we first tested ruxolitinib. And the difference in how people had felt was dramatic. Second, that there was this rapid reduction in the size of the spleen, and that the reduction in the size of the spleen did not seem to be related to any sort of chemotherapy effect. There wasn't tumor lysis, there wasn't uh, a rapid drop in the white blood cell count. So it wasn't your typical sort of chemotherapy type effect. So as we started, we saw it wasn't predicted from PREAT therapy. Splenomegaly and symptoms were dramatically better. Now, the development of the symptom tools, could be its own hour discussion. But we developed it in large part because we needed to be able to measure symptoms. And we had not done this up to this point. We had done some work with survey research with patients and other advocates, folks like yourself, Peter, Joyce Niblack, and others. We leveraged their online community and we had quantified the difficult symptoms that patients could face. But we developed a series of questionnaires because there really were no pre-existing questionnaires to really be able to assess symptoms. Now let me throw a question to Radek. So we saw this improvement in splenomegaly and symptoms. We saw toxicity around platelets and anemia. What could you share with patients listening to this? Again, what did this tell us about the biological relevance of inhibiting JAK2? As a scientist, was the impact what you had expected? Did you expect something different? How do those things connect?
I think the observed effects are pretty much expected from what we know about the function of Janus kinase 2, or JAK2 as we call it. It's an enzyme that associates with the receptors for the growth factors that regulate the numbers of platelets and the numbers of red blood cells. It's also involved in granulocytes, but in MPN, the lead parameters are platelets and red cells. So it was very much expected that if we can inhibit JAK2, that it will lower the platelet count and will lower the red cell numbers and red cell mass. However, the difference with what you mentioned earlier, the BCR-ABL and imatinib, is that JAK2 is an essential enzyme. So if we inhibit JAK2 strongly, then we will go beyond the desired effect of normalizing blood counts. And what becomes key to not just controlling the disease, but sort of pushing it back or eliminating it, would be to have inhibitors that can distinguish between the mutated, overactive, hyperactive form of JAK2 and the normal JAK2. And unfortunately, this is not the case, or it's just a minimal difference in the way the normal, healthy JAK2 responds to these inhibitors and the mutated JAK2 mutant cells. So this is the next frontier, next challenge. So essentially, if we overdose the JAK2 inhibitors, then we create cytopenia. And this is also the problem at later and at more advanced stages of the disease, myelofibrosis, where sort of the production of cells, particularly platelets and red cells, is declining. And if we then try to inhibit blood production without being selective for the mutant cells, then we hit a barrier where we cannot dose sufficiently to actually to push back the MPN cells. And so this is sort of what's going on now. There are the next generation of JAK inhibitors that have been developed, and as you know, there are some that spare the platelets to some degree, and there are some inhibitors that also do not decrease the red cell production, which can be then applied in patients who are already at sort of at lower levels of hemoglobin or even anemia. And the next frontier really is to develop JAK2 inhibitors, which would distinguish between the mutated form, the V617F carrying mutation, and the normal JAK2. So this is what we hope will happen in the next few years. And there are some candidates already now in clinical trials. And so this has been actually very difficult, and it remains to be difficult because the difference between the healthy normal JAK2 and the mutated is just one small amino acid change. And so it has not been trivial to develop inhibitors that would distinguish between the two forms.
Thank you, Roddick. How do you see the future, Ruben, just to finalize?
So where we stand now is that we have 4 approved JAK inhibitors that really inhibit the JAK-STAT pathway: ruxolitinib, fedratinib, pridinib, and momelotinib. They're all important therapies. They all have had patients that have had a very nice response to them. And they all vary a bit in terms of the kinase profile or what they inhibit in addition to JAK2. And there's differences between them, with momelotinib having more activity to improve anemia, pridinib helping anemia, but also being safe with really severe thrombocytopenia, fedratinib not inhibiting JAK1 and having good activity without some of the side effects that we sometimes see with ruxolitinib, such as skin cancers, and ruxolitinib having had the longest arc. So all 4 of those therapies have been very helpful, but they do overlap to not an insignificant degree. And I think they're the base from which we really go. I think what Roddick says is key. I think I would look at the future in several ways. One, there clearly is now an effort to try to go from the inhibition of the JAK-STAT pathway as a whole to be more specific. So there's 3 main driver mutations: the JAK2 V617F, calreticulin, and MPL. And the 4 JAK inhibitors that we've had approved have been active regardless of which of those mutations a patient has. And sometimes even if they don't have one of those mutations, they still benefit. So I view, one, there's going to be the era of more selective therapies. There are a variety of the candidate therapies that Roddick had described that are more specific for the JAK2 V617F. Now, he also mentioned why it's been difficult to develop these therapies. Some of them right now include from Ajax and from Insight in both of those. Now, it'd be very interesting to see what is the impact of these. Are they more effective? Are there limitations? We know that JAK2 is not the only mutation these patients can experience. They can have other additional somatic mutations. So if one inhibits that more specifically, what is that benefit? And does it matter whether you have additional somatic mutations or not? There's also numerous more specific inhibitors that are specific to calreticulin that are in development. Monoclonal antibody from Insight. There is a bispecific against calreticulin from Johnson & Johnson. There are other CAR T therapies that are being developed, as well as vaccines and other approaches. So I think one key thing is we're probably going to move from this era of therapies that work for everyone to therapies that really are specific for certain individuals based on their driver mutations. In parallel, I think there's the era of combination approaches, therapies combined with the JAK inhibitors, which I've already mentioned, that are already approved. with agents such as, in combination, such as pelabresib or naftamadlin or nuvisertib or numerous others that are out there in various stages of testing, some advanced stages of testing, that again look to have either a deeper response or a more profound level of response. And then finally, there are drugs that may be aiming at completely other targets independent of having a JAK inhibitor. So there are the telomerase inhibitors that have shown activity, imetelstat that is in testing, and there's other approaches trying to unravel biology. So I think again, progress is really made with kind of the symbiotic relationship of a laboratory scientist such as Dr. Skoda, who collaborates, who works with others, who again works with us in the clinical research community to really work hand in glove. What's another target? What makes sense? What makes sense to combine? But then as we do these trials, we try to learn from them as well. What do we learn from the responses that are seen with correlative studies or others to further refine either the development of new therapies, help to refine dosing, schedules of therapies, or other approaches. So I'm confident of continued progress because I think the MPN community is really an amazing community, and it's really developed with tremendous mentorship from Dr. Skoda, Dr. Green, Dr. Venchenker, Dr. Gilliland. They've really mentored a generation of MPN scientists that are continue to expand this work, across the world. Everyone from Yoti Nangalia, to of course Ross Levine, who's become very senior in his own right, who had trained under Gary Gilliland, to Robert Kralovitz, of course, who's now very senior in him himself. So again, they've really mentored another generation that continue to move these things forward.
Thank you very much, Ruben. Roderick, before we end, do you have anything to add to this, or?
No, I think we have covered most of the topics. I think one aspect is maybe still worth mentioning is interferon, which is a drug that has been used in many different contexts and was pioneered by Richard Silver, and now in its pegylated form has actually become currently the only drug that in some patients can induce molecular remissions. And this is, again, something that works kind of independent of targeting directly the JAK2 mutation. Rather, it seems to work through exhausting the pool of the mutant cells, the mutant stem cells. And so I think for the future, of course, it will be very important to find better and more effective treatments for advanced stages of the disease. But an important field in my mind is also to move towards therapies at the early stages of the disease, and even at stages sort of preventing the conversion of carrying the mutation to developing MPN. As in essentially all cancers, eventually early interventions tend to be more effective. And so there's a clear logic why the therapies that are currently approved have been tested in advanced stages. That's true for all cancer. And it's more difficult to do clinical trials at the early stages because the endpoints need to be defined to sort of prove that a new treatment is effective. But I think for the future, clearly we have to find ways to move to the early stages of the disease to prevent the progression and to have more patients like yourself who can say, I've had PV for 30 years. So this is, I think, what we thrive for.
To achieve, yeah. From a patient side, I simply would beg you ask you, don't forget the symptoms. The symptoms are very, very important for a patient. We have too many patients who are, based on the analytics, they are stable, they're okay. From that side, is everything is good, but they feel terribly bad. Because sometimes because of side effects, sometimes because simply the symptoms which we are having are simply too strong. And I mean, you all know the symptoms which you're having. I don't have to list them now. But please, in all this work which you're doing, which is absolutely fantastic, please do not forget the symptoms. It's very important for us. Most of us are in one or the other way. We are suffering from the symptoms. We learn to accept that we do have these symptoms, and we try our best to keep on going and to keep on fighting. But please, I know many pharma companies they're changing, and they really look at the symptoms and try to battle this also. And I'm for sure I know that you're also doing that. Anyway, so I think a little bit over time already. I want to thank you very much, not only you, but also your colleagues, which have been working with you, all the names which we both of you mentioned. Without you, we wouldn't be where we are today. And I can tell you as a patient who lived it, the advance which we made thanks to you and your colleagues is absolutely great. And I just wanted, in the name of all the MPN patients, give you a great thank you very much for fighting, for giving us a better life. And we trust you so much, and we know, but also the symptoms one day we will get them under control. I'm sure of it. So thank you very much for being here. It's a great pleasure to have two of our main pillars of our MPN family. Thank you very much, and good luck. Please keep on fighting. Yeah.
Thank you. Thank you very much.
Bye-bye. Wonderful discussion. Thank you, Peter and Radek.
It
Yes,
was a
thank you.
pleasure. Thank you very much. Yeah. Okay. Bye bye.